Hello, I'm Norman Swan. Welcome to this program on depression in adolescents and young adults. Adolescence and young adulthood is when many mental health problems such as depression, anxiety and other mood disorders first show themselves. It's a time of transition and personal challenge, not to mention risk-taking, including drug and alcohol use. And it can be hard to detect depression in this age group, and young people can be reluctant to seek professional help. Clinicians find this confusing and a bit scary because they've been told about the risks of antidepressant medications and can be unsure about the best way to engage young people in their ongoing care and assist them in recovery. So tonight we're going to cover prevention, diagnosis, treatment and follow-up for young people aged 13 to 24 who are experiencing a depressive disorder. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. and on the Beyond Blue website, beyondblue.org.au. Now let's meet our panel. Jeremy Mann is a 22-year-old university student and youth ambassador for Beyond Blue and has a personal experience with depression. Welcome, Jeremy.
Good evening.
Jeremy is also a member of Blue Voices, Beyond Blue's Young Persons Consumer and Carer Reference Group. Chris Davey is a consultant psychiatrist at Origin Youth Health in Melbourne, where he leads the clinical and research program in mood disorders. Welcome.
Good evening.
Ross Wilson is a rural general practitioner from Bathurst, with over 30 years of medical experience. Welcome, Ross.
Good evening.
Ross also does regular remote work in the Kimberley region of Western Australia. And last and certainly not least is Brian Grates, who's program director at Beyond Blue, the National Depression Initiative. Welcome, Brian.
Hi, Norm.
Brian oversees a range of national programs in education and early childhood settings, focused on mental health promotion, prevention and early intervention. So welcome to you all. Thanks very much for joining us on the program. Jeremy, take me back to that first time when you realised there was something wrong with you.
The first moment I realised there was something wrong with me and I desperately needed to seek help was actually one of the lowest points of my life. It occurred at an incident of self-harming, and that was the moment I realised that I had completely lost control and I needed to seek help to get my life back on track.
How old were you?
I was about 19, just turned 19, and yeah, it came as quite a shock. I didn't realise that somebody at that age could just lose control.
Do you want to tell us more about what happened?
Oh, certainly. The signs and symptoms of depression had been with me for many years, but I just thought they were part of growing up. It wasn't until that my father passed away to a relatively short battle with cancer that it really triggered a bout of severe depression. I moved through a grieving process and moved on with my life, but life never returned to normal. And I began to realise that I was calling it grief, but it was actually depression. And
what were you feeling?
I was constantly feeling down and depressed and all the obvious signs and symptoms. I wasn't myself, my behaviour was changing, and I would be down for weeks on end, which just began to ruin many aspects of my life.
And the self-harming? What led to that?
Sheer desperation. I felt there were so many things wrong in my life, and I felt there were so many things that were wrong with me. I thought it would be an outlet for all the pain that I was feeling and going through at the time.
And was this self-harm or was it a deliberate, were you trying to commit suicide?
At the time, it was so difficult for me to understand what I was doing. Now that I look back, I don't think that I would have actually taken my life at that moment, but the thoughts were certainly crossing through my mind. And I looked at that attempt as an attempt on my life, yes.
Had you come close to looking for help or seeking help for your feelings before that?
Yes, I certainly had. I had attempted to speak to a number of counsellors through my university, as well as a few close friends, but I didn't find the help that I desperately needed, and that was very discouraging, and that continued sort of my spiral onwards. So,
tell me about the conversations you had prior to this episode of self-harm. Yeah. Just replay the video for us about what the conversations were like and what you went in with, yeah, and how it was responded to.
I would express a lot of things about how I'm feeling, about how my life was going, and a lot of uncertainty. And the common response was, oh, you're just going through a difficult time, your father's passed away, let's go through some breathing exercises and you'll be right as rain tomorrow morning.
Yeah,
yeah.
Yeah.
And
like in and out?
Yeah, and taking time to have normal breaths and things like that. And for the help that I was seeking, it wasn't really appropriate.
Jeremy, just from a GP's point of view,
yep,
had you actually gone to a GP, any primary healthcare provider, and put your symptoms out there, or Were you avoiding doctors, or were they impossible to see? Or
at this stage, I thought there were a lot of problems with me, and no, I had not seen a mental health professional or a GP. I was just, dabbling with counsellors at the time, hoping that that was the avenue that I could find to find somebody to talk to and seek treatment. And it wasn't until the self-harming incident did I actually realise this is a lot more serious than I anticipated, and I really need to go and speak to a proper health professional in terms of a GP who could provide a much better form of treatment.
so after the self-harm, did you take yourself to hospital, or did you just present to a GP surgery?
I essentially saw my local GP, a GP I held a lot of trust in and had a relationship with, and basically rolled up my sleeves and said, this is how my life is going and this is what's happened, and just presented everything to her as it was. As you can imagine, it was a lot of pressure on her quite suddenly. She wasn't the common cold I walked in with.
Pretty hard. Sorry, Rob.
Yeah, sorry. How do you feel that your initial presentation was received by the doctor?
At first I was very nervous. That I still had a lot of personal stigma about depression, and I thought there was something wrong with me, but that my GP's response was very positive and very much of let's get you some treatment and let's get you recovered. And when I walked out of the office, the impression that I got from her was very positive, and that was an important stepping stone. Essentially it was the first stepping stone towards my recovery.
So give us the story of the track to recovery, because I bet it wasn't smooth.
No, it wasn't smooth at all, and one of the biggest issues I had was finding someone to manage my treatment as well as monitor my health.
But wasn't that your GP?
Well, to some degree it was, but my GP has a very heavy patient load. So booking in, when I'd ring the phone to say, hey, look, I need someone to speak to, I feel like my life's, my treatment's going off track and I'm feeling quite depressed at the moment, that's when my GP would say, oh, we've got an appointment coming up in 2 weeks. That wasn't just acceptable.
So there was no lubrication to actually get you in faster?
Not initially, no. It wasn't until the seriousness of how sick I actually was and how depressed I actually was settled in with the staff at the surgery did they realise that I was a priority patient.
So do you think there should be triggers for younger people or any depressed person at the GP surgery? I mean, our reception staff are often used to pressing the button when somebody says chest pain or shortness of breath or abdominal pain or something along those lines. Do you think there ought to be mental health triggers that would get reception staff off their backsides to do something?
Oh, most certainly. In fact, a lot of people who will be in that situation will be at one of the lowest points in their life when they need help the most. So being able to recognise those triggers is very important, but it's also important that GPs are able to say to their patients, if you feel you need help fast, these are the people you can contact, this is what you can say, and this is what you need to say to my staff.
What do you do, Ross?
I have one trigger that works for my staff, and that is, oh, don't bother. If a young person says, oh, don't bother, that's a trigger to my girls to take this slightly more seriously, because that problem of engagement with the adolescent is an extremely difficult one. And if they've got to the stage of actually getting encouraged to ring for an appointment, and they get the usual, sorry, it's 2 weeks or 6 months, and then they say, oh, don't bother, the girls know that this is more significant, because if they've had the courage and then they back away, I think that's a significant trigger. The other thing is that I always, with patients that I know are depressed, I do a sort of summation of just how depressed they are, and I'm prepared to give them my personal mobile number, which is normally only available to the hospital, if the crisis is about to occur. Or I give them, if it's to me less of a worry, I give them a string of numbers of people who are readily accessible that they can use, the mental health team at the hospital, a couple of psychologist numbers who have agreed to
and
be
often
part
it's reassuring just having those numbers, and you probably never use it or rarely use them.
Well, they rarely use it. I can think in the last 5 years where I've been conscious of this risk of suicidality, I can only think of 2 occasions when an adolescent's actually rung me and said, I'm desperate. I can think of a lot more occasions when adults have done it, but only 2 when adolescents have done it.
So what treatment did you have?
My treatment was a careful balance of a range of aspects, including things like cognitive behaviour therapy as well as medication, and a lot of significant changes in my lifestyle at the time. And I took a lot of the responsibility in managing that and monitoring that and reporting to people that were assisting me.
Were you using drugs or alcohol a bit too much?
Yes, I was self-medicating. I worked in an environment where alcohol was freely flowing, and it was easy to just go to work and forget about the rest of life's troubles and
anaesthetise yourself.
Exactly, and that became a big problem at some stages.
Common story, Chris.
It is a common story. You know, I'm impressed by the fact that your ticket of entry to the whole system was harming yourself. I think young people often have a lot of difficulty sort of accessing help for their mental problems. It's
not good if it comes to that.
It's not an uncommon story. I mean, young people generally are fit and healthy and well, and they're not used to having to access care for themselves. And you know, it's unfortunate. It often does take you know, an incident like hurting yourself to get that entry to the system. It sounds like once you got the entry, your treatment was really good, and you recovered.
What happened to at university, friendships, that sort of thing?
Well, my life took a real spiral downwards. There were some mornings I would wake up already crying, and getting out of bed just became a morning-long battle.
This is even after treatment?
This is during treatment, and yeah, and it reached the point where I would miss so much university I couldn't keep up. I would use up all my sick days with work, to the point where it was detrimental to every aspect of my life, and I couldn't continue a normal life.
How long before you came out the tunnel?
It was about, after I guess I sort of initially went into the doctor, it was about a 6 to 8 month period that my treatment began and my recovery was. But, you know, it was a case of this is where it began, and I'll take as long as I need to get back on track.
Brian, is that a sort of typical path?
Yeah, it's quite a long course, you know, for depression. It's generally you know, for kids who have been depressed for a time, and for young adults depressed for a time, it's not really a quick fix here we're talking about. It actually is quite a long course of, you know, of help and treatment that's really required. And I was pleased, you know, for Jeremy, he's talking about getting psychological help as well as medication, you know, which generally has better outcomes.
And has it come back?
There are some mornings and some days when difficult things happen, but the important thing is I've built up a lot of resilience, and I know my experience in the past, and I've built resilience from it, which I carry on into the future. And I feel that my experience of in the past have prepared me much more, and I feel like I'm a much more resilient person.
We throw this word around, resilience. We'll have a little bit of resilience here and a little bit more there. What does resilience mean to you, Jeremy?
Well, to put it as simply as I can, is that being able to get back on the horse when you get knocked off. And I know that's sort of an old saying and things like that, but
can you dissect it even further? What are the components of that strength? What is it that sits behind that?
For me, it was just being able to achieve what I should be achieving. And what I mean by that is that when things were going wrong, to say, look, I know they're going wrong, and I'm not going to let them get to me and build up like they did before. I'm going to have the courage to move through them, and the resilience to build upon.
And how much was it the cognitive behavioural therapy that gave you that ammunition?
Well, a lot, because there were a lot of aspects of my life that were negatively affecting my depression, and by removing those, I was able to sort of use that behaviour therapy to change my lifestyle, and once that change began to occur, recovery could begin.
How often do people relapse, Chris?
Relapse is common. I mean, the course of depression is variable, so a portion of people only ever have one episode of depression. But well, probably at least half will go on to have further episodes of depression. And it appears that the more episodes of depression you have, you know, the more likely you are to have a recurrence.
So best to get it under control and try and prevent
best to get
relapse.
Early treatment, and there's some suggestion that early treatment may, you know, reduce the risk of relapse. And especially, I suppose, an important point is to continue the treatment for a period after you feel like you're better from your depression, to try to prevent relapse in that first year.
So Jeremy, just finally, what tips do you have? I mean, do you know in a situation when you walk into a GP surgery, you know, oh God, this is going to be hopeless, they haven't got a clue about young people, I'm going somewhere else, or, you know, what your tips for design, how you talk to people, how the receptionists behave, that would make life easier and more user-friendly for young people?
Yeah, most certainly. I think one of the biggest things that affected my journey towards recovery was stigma. And I think a lot of people carry stigma with them when they walk through into the GP's office or when they talk to people. And it's really important to just leave that on the door, because there's a lot more important, lot of things that are very important that you need to discuss with a professional.
But what is it they can do to make it better for you?
Well,
that's what you're leaving at the door. What can they leave at the door, or what can they design into the system that makes it more user-friendly for somebody who's 19 years old?
Yeah. By simply listening to what the 19-year-old person has to say or young adult has to say, and then by sort of beginning to form a relationship and a bit of a plan for treatment is definitely the first step and the most important thing.
So you don't have to be hip.
No, you don't. You certainly don't.
Dr. Wilson is feeling incredibly relieved here.
Yeah, my hip days are well past.
That's right.
Jeremy, we're obviously looking for the entree to the general practice surgery. Does the atmosphere in the waiting room, anything like that, make a difference? I know in the Headspace unit that's in town, we've placed a lot of emphasis on the right sort of furniture, the big screen TV with the MTV show going continually, and I think I know most of the rock songs off it now. Is there something that sort of breaks the ice for you? I mean, most reception staff are better than 55 years old. Most have got their walking frame parked behind the desk as well.
Your life's going to be hell the minute you walk into the surgery tomorrow morning, Ross.
I should hope this doesn't go to the girls. But do you feel younger receptionists, right music, anything like that would make a difference?
Look, there's a range of things you could look at, but when I first went into the doctor's surgery and sat in the waiting room there, the person next to me had a cold and the person on the other side had a broken leg, and I'm thinking, what's wrong with me? Have I really got an illness that is worthy of a GP's time? And then I would sort of look up and see this poster that was talking about mental health and about how depression can affect anyone. And that built me a lot of confidence that, no, I have a legitimate problem and that I'm
My God, the benefit of a poster in a GP surgery. I've never heard this before.
No, it's very true. We've found it with Aboriginal patients that if you've got some Aboriginal-friendly art in the waiting room, they feel much more comfortable. So I can see how a mental health poster might help.
So, Chris, how prevalent is depression and mood disorders amongst young people, 13 to 24 group?
So depression, in the years before puberty is quite rare. From puberty it really takes off, and more so in women than in men. So there's data that suggests by the age of 25, about 1 in 5 young people will have suffered depression.
Is it on the rise, Brian?
Certainly there's lots of reports in terms of hospitalisations and reports to GPs that the mental health problems are taking precedent here. But there's also the other side, or the other issue, that recognition is so much greater in the community. So, and we've still got a lot of work to do about that, but recognition's greater amongst certainly young people about some of the problems, but also within the specialist health areas as well.
What are the risk factors, Chris?
Well, the risk factors, there's the sort of risk factors which you can't do an awful lot about. Things like family history of depression, which is an important one. Your gender, like I said before, it's much more common in women than in men. Past traumas are important risk factors, particularly childhood sexual abuse, but early parental loss. But then there's the sort of risk factors which maybe you can do something to intervene with, and they're things like substance use, the presence of some depressive symptoms, difficulties with peer relationships, difficulties with family. And they're the sort of risk factors which you might hope, some of your ability to influence them are limited, but others, early identification of them, could really help.
What are the data these days on delay in diagnosis? I know that bipolar is still considered quite late, that you've got it for 3, 4, 5, sometimes even 10 years before it's diagnosed properly. What's the average delay in diagnosis?
I couldn't really tell you. Chris might know better.
The National Mental Health Service suggests that only about 30% of people get adequately treated.
I can say people who eventually receive a diagnosis of bipolar disorder commonly present with depression first. So part of the delay in diagnosis is that the bipolar part of the illness hasn't declared itself yet, and it doesn't declare itself till later. But there is often, there's the time between first experiencing depression and getting treatment, is often years.
Tough times in rural towns can't make it easier either.
Yeah, we've experienced almost an astronomical increase in depression amongst our rural youth, purely and simply because of the drought. We've had 8 to 10 years of drought, depending on where you are, and that drought has left the same feeling of helplessness as you experience our Indigenous population. And that feeling that you're being dispossessed, that you're not of any value, people walking off farms, unable to find employment in their local town, and they either remain there on the dole, and that sense of helplessness that goes with that, or they drift off to the major cities. It has been a very depressing time in rural Australia.
Brian, what do we know about groups such as Aboriginal and Torres Strait Islander groups? I know that Beyond Blue is interested in gay, bisexual. You said that adolescents and young people who are gay or bisexual have increased incidence of depression and anxiety.
That data is pretty limited on this stuff, but what data there is clearly showing that some groups have higher rates. So Indigenous populations have much higher rates of hospitalisation. And for the 2007 ABS survey, for those who indicated they were gay, they had rates of depression and anxiety 2 to 3 times what the other population was indicating. So those groups, as well as refugee groups, newly arrivals with the transition issues into Australia and the challenges that faces, kids who are in care, foster care or institutionalised. There's a lot of vulnerable groups in our society, and they also relate to kids who are basically in regional areas as well as being another vulnerable group around this.
Ross, do you have issues with diagnosis? Do you find it difficult?
I think the most difficult issue in diagnosis is engagement, and that is getting the first foot toward the diagnosis by engaging with the person is often the hardest thing. And that is based around, I think, the fact that they tend to present later, they tend to present with very vague symptomatology, they tend to also try and trivialise some of their feelings. That feeling of helplessness, that feeling of lack of pleasure at doing anything is often minimised. They'll just say, oh, it's probably the stage I'm going through. Whereas if you start to dig a little bit deeper and recognise the signs earlier, it's quite often comes flowing out and the diagnosis becomes fairly self-evident.
So you ask the same questions as you'd ask of an adult, but you just go about it perhaps a different way.
Yeah, you tend to need to go around the side rather than hit it head on. I mean, adults are more used to being confronted with things, and the question, do you feel depressed, to an adult often doesn't seem out of place. Whereas if you say, do you feel depressed, to an adolescent, it's almost an insult because they're never depressed. And until we recognise that 1 in 5 is going to be, then we're often going to miss it.
A question here from the audience, Chris, a nurse in Lismore in northern New South Wales. How significant is the role of a father in the mental health self-esteem of a teenage boy? She's thinking of an attempted suicide of a young man whose father left the family home at the age of 12. Is that a risk factor?
Parental separation is a big risk factor. And we talked before about some of the evidence that rates of depression are increasing over the last few decades. And I think, notwithstanding some of the other factors that are important in rural regions, I think breakdown of the family, parental separation, are big risk factors. And a lot of young men have very little contact with their fathers, and particularly in Indigenous communities. That's one of the big risk factors. For young Indigenous men, often have very poor relationships with their fathers. That's undoubtedly a big risk factor.
Brian, a question from the Darling Downs in Queensland. How significant is the rise of obesity in young people and its relationship with depression?
I'm not sure of the data around that, but clearly issues around body image and eating disorders are really prevalent in terms of looking at what are the drivers around kids experiencing depression, and it's undoubtedly the kids are saying clearly that for a lot of them they have a very negative body image around themselves, and clearly that would be related to sort of their levels of obesity and other problems.
Another question from just north of the Central Coast in New South Wales. Is there a role for mental health professionals in conducting prevention programs in high schools, or should we train teachers? Tell us a little bit about prevention and the sort of intervention programs that you've got going. Yeah,
there's around in terms of prevention programs have been going for some time. The idea that can you inoculate kids or students from experiencing depression? So in many ways it's like the holy grail, and Beyond Blue's been in that space for some time. And the programs generally are programs that have been derived from clinical settings like cognitive behavioural programs. The role of Beyond Blue's taken is very much trialling some of the best programs that have been out there. And they're generally a mix of skills-based programs, the sort of skills that Jeremy was talking about learning in his sessions, the self-talk skills, understanding the link between what you think and how you feel and behave, and how you might apply some skills around more helpful beliefs, how you develop some more helpful beliefs and attitudes about yourself. And then there's also the school environment we focus on. So the idea that Jeremy used the word resilience, that just doesn't happen in a vacuum it actually happens as part of a school context. So how user-friendly the school is, what are the relationships like with teachers? Do they have someone they can talk to if they need to? The evidence is pretty patchy around this stuff. It's very hard for schools to get curriculum space, to do the skills-based stuff. And schools are carrying the load around a lot of public health agendas. But clearly, there's...
So there is evidence that they work?
Well, some programs have had some success, but the big issue of this is replication, that generally, when they've trialled again and gone to real life settings, so gone from the efficacy to the effectiveness trials, they've struggled a bit, but because the impact is so significant.
Do you have a list of programs that you recommend?
Beyond Blue doesn't have a list of programs. There are many programs out there that schools utilise. The programs that specifically target depression and anxiety, the areas we are, which have the most evidence for effectiveness, would be undoubtedly Mood Gym and Friends and RAP.
Chris, if you've got a family that is separating, is there preventive action that you can take? Or is it a bit like, trauma counselling, where you can actually make somebody worse by foisting yourself on a situation before it's arisen?
There's possibly some truth to that. I think the most important thing is to be sensitive to them, to the young person being vulnerable to developing a depression.
Keeping an eye on things.
And keeping an eye on things and making it clear that you're available, to be contacted and encourage the young person to contact you should there be a problem with their mood. So
we've got two GPs, one in Victoria and one in South Australia, asking about SSRIs, antidepressants, and whether or not the pros and cons in adolescence, and also the use with CBT. We should really at this point talk about the clinical guidelines that are being developed by Beyond Blue. Just tell us a little bit about those clinical guidelines, Brian.
Well, Beyond Blue's taken on the role of doing the clinical guidelines for youth depression, and the last set of guidelines, which came out in 1997, were rescinded in 2004. So there's been quite
and by rescinded, you mean they just get out of date?
Well, they got out of date, and it was particularly around the antidepressant issue. There was a burgeoning research in this area, and community attitudes around depression had changed, and the prevention programs had taken off. So there was a real need to really go and review the area. So effectively, in terms of the guidelines, they're in the process of going through a final review and going to peers. But it's clear that some of the recommendations they have should provide GPs with greater confidence around their treatment. So particularly reiterating that psychological therapies, cognitive behavioural therapy and interpersonal therapy are effective first-line treatments. But there is clearly evidence around SSRIs, in particularly fluoxetine, as being effective, but for those specifically around the moderate to severe end of depression.
But just to tease out this issue of antidepressants, because there have been scare stories in the media. People top themselves when they take an SSRI, they become agitated and raise the sign of the cross, and GPs are scared to prescribe them. Well,
I'm not surprised. I mean, there's been quite a bit of literature over the last few years that's called into question the effectiveness and safety of SSRIs and antidepressants generally.
So what's the evidence?
People. So the evidence, as it exists, is not extensive, and for many of the antidepressants is equivocal. The reason that fluoxetine is now suggested as the first-line treatment is there are some reasonably large, good quality, randomised control trials that have shown that fluoxetine is effective for young people with depression. For other antidepressants, for the other SSRIs, and particularly for the newer sort of antidepressants, the antidepressants which have different mechanisms of action, there's very little evidence that they're effective. So on the one hand, you've got this question of effectiveness. On the other question, you have the other hand, you have this question of safety, and that is, this literature around the emergence of suicidal thinking on starting young people on antidepressants, and looking through all the trials suggests that while the emergence of this suicidal thinking is rare, it is increased in the young people taking antidepressant medication compared to placebo. So roughly about 4% of people taking antidepressant medication will experience this increase in suicidal thinking compared to 2% on placebo. Now, there are important points to highlight, I suppose, in this. One is that there's no evidence of any completed suicides. In fact, none of the trials had any completed suicides. So we're talking about suicidal thinking and in some cases attempted suicide. It seems to emerge in the first week or two after starting treatment. And then, of course, using antidepressants, the hope is that it reduces suicidal thinking and suicidal ideation, and there is evidence around that. So probably what is happening, in starting antidepressants in all age groups really, often in that first week it can have some sort of activating, agitating side effect. And in a young person who's already depressed and a bit wound up, that might sort of be what tips them over into then thinking about suicide.
What happened to you when you started your antidepressant medication? Did you notice any side effects?
My GP did warn me that it would take at least a couple of weeks before I began to notice any changes in my sort of behaviour and my emotions and things like that. So that prepared me for sort of a longer, more drawn-out recovery period. But I knew each morning that I needed to take my medication and that it would ultimately...
And did you get any of this agitation or bad thoughts coming into your head?
Not that I could blame on the medication.
No, you had it before.
It's a difficult area and there's no way you can pinpoint.
And it's not common. I think it's not common.
So at what process do the guidelines say that you start to think about medication? Because the guidelines say, first of all, you think about psychological therapies, the two with evidence, CBT and interpersonal
I mean,
psychotherapy.
for milder depression, I think it should always be first line. For more moderate, severe depression, I think medication should be brought into the conversation, and obviously it'll largely depend, well, entirely depend on whether the young person is up to taking it, and often that would involve a conversation with the family. But the two, of course, aren't mutually exclusive, and there's good evidence to suggest that therapy plus medication, is the best treatment of all. And it's a matter of, often, a trial of therapy might be the suggestion. Let's see how you go with 4 to 6 weeks of CBT. If things really aren't getting any better,
and
if you think of medication.
Some people believe that if you misdiagnose bipolar and you start them on SSRIs, you can make them worse.
I mean, that's certainly true, and that adds more uncertainty into the mixture. So the significance of making a diagnosis of bipolar disorder is antidepressants, one, aren't very effective for bipolar depression, but secondly, run the very real risk of triggering a mania and making their mental health a whole lot worse.
So you really want to ask about manic or hypomanic things, Ross?
I usually, if I'm on the track of depression, ask the highs and lows question, and if there are significant bipolar, even bipolar 2 symptoms in there, they will admit to highs.
And just to remind us, bipolar 1 is where you get the frank, dangerous, manic, or potentially dangerous or mad manic episode, and bipolar 2 is where it's more of a mild high.
Hypomania, where they're just floating and the world's their oyster and they've got all the energy in the world and they clean the house in 45 minutes.
Not if you're 19 years old.
Well, they clean up their bedroom, might be just sufficient. But I always ask the highs and lows question. If I get a highs in there, I will hang back on prescribing anything until I've had a significant discussion with some other mental health provider. I guess I'm fortunate in that we've got 2 psychologists who work in conjunction with us in our rooms, and with depression in adolescence, we always get them an urgent appointment with a psychologist as soon as we've thought depression. And the psychologists are fortunately prepared to fit in appointments either before or after their normal sessions for an adolescent. They won't do it for adults if you've got to the depressive stages.
And will they bulk bill?
Yes, they're done on the Better Health Outcomes 2710 schedule. And we then sort of have a corridor consultation after the first evaluation, and the psychologists will often say, I think I can do this one all on my own, or no, I think we need some medication. Now, if the question of medication comes up, we then have a little bit of a dance act where I'll see the person, say, this is the medication we're going to start, warn them about a few of the side effects, including the possibility of suicidal thoughts, give them a contact availability, and then dispatch them to see them again at the 2-week stage, or before if the wheels are falling off faster. And at the 2-week stage, they'll have had hopefully one more consultation with a psychologist, and at the 2-week stage, I get some idea of how effective the medication side of things is. But I always tell them not to expect too much, but I'm mainly looking for serious side effects and whether we've got the diagnosis wrong, in that if they become more manic, I start to get very worried that I've missed the bipolar diagnosis.
Yes, I mean, that first 2 weeks I think is really important for getting a sense of how they're going to tolerate the medication. It's probably too early to say whether it's going to be effective or not.
It's tolerance.
But yeah, that's right. Yeah. And unfortunately with these medications, all the side effects emerge, in the first few weeks. The good effects you don't see for
And Brian,
for
do we
another month
know the
after that.
dosage of CBT and interpersonal psychotherapy that gets you the effect?
Well, they generally will go for 10, 16 sessions to get the effect that they're looking for in terms of an outcome around depressive symptoms being reduced. But it is something that clearly there's a need for booster sessions as well.
We've had a question from Western Australia asking about the comparison between face-to-face versus online.
There's
therapy.
probably emerging research around that. The online technologies have really just come on board in terms of the randomised controlled trials, which the guidelines we're looking at. They're probably still yet to be done, but clearly that's one of the great possibilities going forward, that you will find, particularly around rural remote areas, access to online programs. There's certainly some out there now, like Mood Gym, eCouch, which we clearly would recommend and use for people.
And there's some
to access.
randomised controlled trial evidence that even quite severe depression can be helped. Have you ever tried them, Jeremy, the online therapies?
I did. When I was initially researching depression and things like that, I had a look at some of the resources that were out there and some of the therapies that were online. Gave some of them a go, but I was beginning to reach a point where simply looking online and finding an answer or Googling it wasn't the easiest approach.
Let's go to our first case study. Catherine's 16 years old, lives with her mother and 2 brothers. Her parents recently separated and she and her family moved to your town, Ross. Her mum brings her in to see you because she's concerned that she's been at the top of the class at her previous school, but she's now struggling.
Well, I guess the first thing is to establish that rapport. She's a new patient, she's come in with a mother, and I'd initially talk with both of them, but with a proviso that at some stage during the consultation I want to flick mum outside and have time one-on-one with Kathy. And I'd ask her permission to call her Kathy, because I don't think many adolescents would take you calling them Catherine for too long. It sounds like very disciplinarian. And I'd explore the fact that her school performance has fallen. I'd explore the fact that she's been socially dislocated and the family's dislocated itself. And those
So she gets teary when you start talking to her about it, and she says she just hates her new school, they all hate her, and she just wants to be back where she was before.
Well, turning back the clock's never a responsible way of dealing with it, and we all know that, but you'd never bring that into the consultation. What you need to say is, we're looking forward here, but I think we need to do something about your mood before we do something about anything else. And that gives me the intro.
But it's not my mood, I'm just hopeless. I'm just a hopeless person. For some reason, I just used to, everything was perfect. I got my homework in on time, I got top marks, and I'm just hopeless. I just can't succeed.
Well, I think we go to the situation that, okay, in your previous life, you had everything intact. Now things have been scrambled a bit, and do you think it's a case of your mood is making everything look worse than it really is? And with that mood that you've got at present, are there things that you're not enjoying in life?
I'm not enjoying anything.
Is your sleep pattern good?
I'm waking up in the middle of the night, can't get back to sleep.
And that to me is a cardinal sign in an adolescent that things are depressed. Once they start to get sleep disturbance, it's a very worrying thing, because teenagers will sleep through the atomic bomb and for the day after. So once that's there, I actually will phrase the question, do you think your mood's depressed? And most of them, when you're given that trigger and they've established by this stage some sort of discussion with them, will say possibly or yes. It's then probably time to hive off mum, if you haven't already done it, and start a one-on-one about the sorts of experiences Kathy's had up until then, the sorts of other things that might be going wrong in her life.
Would you ask about suicidal ideation?
Oh, that comes in. But I again wouldn't go straight to it. It needs to be in the discussion, and it needs to be something that's sorted out before she leaves that room.
So she tells you that she is so hopeless in this new place, she hates it so much, she has thought of ending it, and when you ask her if she's thought about the means, she said she has thought, she's a learner driver, she has thought of taking the car out.
I reassure her that those sorts of thoughts are common in all of us, and that it would be a lie for any of us to say that we hadn't had that cross our mind, but it's the thinking and the doing that are two separate issues. And what I'd need out of her is a trust that if she was considering something like that before she took any action, she contacted me. And it's at that point that I'd provide an immediate access number for her and a guarantee that we were going to work through this problem, that we were going to engage some other people in sorting out this problem, and that we may need to use some medication to try and lift the mood so she can see the light at the end of the tunnel.
Brian, is it possible to be so locked down in your depression that it's really hard to lever up with cognitive behavioural therapy or interpersonal psychotherapy?
Absolutely, and that's the real issue for to do psychological therapies effectively. You've got to have an adolescent who's at least can engage in the thinking processes, around all this, and clearly one of the main symptoms is their incapacity to concentrate and to exert effort around this stuff, and that's clearly where perhaps some of the medication might be of benefit, that you can actually lift the symptoms to a sufficient level, lift their mood to a sufficient level that effectively they can engage in some of the talking therapies.
So that's the fine call you've got to make. You want to comment on that, Chris?
Yeah, I'd agree, really. I guess there are some young people who just aren't up for therapy as well. It does take a certain sort of level of organisation to get to an appointment each week and, engage in something which requires a lot of reflection and ability to do the work. And, in my experience, I think most young people are up for it, but there's a good portion who just aren't ever going to engage in a therapy. And I don't think you should discount medication with them, and it has the added effect of keeping them engaged, at least with a health professional who can monitor them and keep a close eye on things. And
Ross, you've assessed her at serious risk. She refuses all treatment. What are you going to do about that?
I think that's the stage when I, with her permission, call Mum back in and say, look, part of the people that we need to engage in getting you better is going to include your family. And it would be extremely unusual for her at this stage, being from a single parent family now, that she would refuse that offer of assistance. If she says, no, I don't want Mum involved, I say, well, who else can we involve? Is there an aunt, an uncle, a grandparent that we can use as your reference point, your rock, your stone that you can cling to when things are getting rough? And if she's got a significant other that she can cling to, then we've got a point, and we can involve that person partly in the protection process, but also in the follow-up, because that person will then act as the reminder, look, you need to take your medication, you need to attend your sessions with psychologist, doctor, etc. like that.
So what would you do, and I'll bring Chris into this on Brian, if you got the strong sense, or she admitted to heavy drinking and heavy cannabis use?
In my case, at that point of time, I would say another one of those people that we need in this equation is our drug and alcohol counsellor. And I don't care whether there's a cast of thousands involved in the care of this person, as long as the care is maximised. And I guess I'm fortunate in being in a large enough town to have those facilities.
Chris, what do you think?
Undoubtedly, heavy cannabis use and alcohol consumption are real risk factors for depression. Alcohol particularly is a risk factor for suicide, so it's really important to address it. It can be difficult, sometimes just to prioritise which you target first. And I guess in the case of this young woman, our first thing would be to maintain her safety, to make sure, that we feel like we've done a risk assessment, we have a plan in place to keep her safe. A lot of young people aren't really ready to deal with their substance use straight up. And it might be more, trying to keep them safe target their depression, but always kept it part of the conversation because it's, such a big factor and one that's quite easily it's a reversible factor. The fact they're using.
So did you have any useful help for your? You're obviously in an environment where you could drink to treat yourself. How did you deal with that? How did you get help specifically for that, or that sorted itself out as your depression lifted?
Yeah, to a degree, it began to sort itself out as my recovery continued. But at the initial stage, when I first saw my GP, it was much easier to see the barman than it was to go and see the pharmacist. So it wasn't a sudden change; it was a very gradual change. And at the end of my recovery, I looked back at my alcohol and drug consumption compared to previous times, and it was just two different people.
Started to solve itself. Do you want to comment, Brian?
No, I think Chris's point around the issues are quite often intertwined, and I think getting some priorities and keeping them engaged is probably the most important thing.
Another good way I've found of engaging them is if the school has a peer support program. And quite a number of schools locally have got a vertical peer support program where you've got Year 12s looking after Year 6s and such. And they've got somebody that they know in a year above them or a couple of years above them that they can feel free to talk to. And in charge of each of these peer support groups there seems to be a nominated teacher. So you often find out which school they're at, which particular teacher is in charge of their peer group, and a quiet word in that teacher's ear often triggers the peer support that's valuable as well.
The network and the supportive environment, because supportive environments are incredibly important, Chris, as evidence has shown, particularly in Victoria.
Yeah, absolutely.
Let's go to our next case study, who's James, 14 years old, lives with his parents and his older sister. When he was at primary school, he had a history of truancy, but then it sorted itself out until about mid-year 7, and he's really currently not attending school and mainly playing on his computer at home. Mum brings him in desperation. Ross?
Looking at our young lad in the photo, I've got the impression that this boy would be the ideal target for bullying. So my first question when Mum mentions the truancy issue is this a bullying issue? And if it's not a bullying issue, then I've got to start to look at, again, the depressive side of things. Although truancy generally doesn't, to me, trigger a lot of bells about frank depression. Maybe this dysthymic individual's more the case. And I tend to use the old-fashioned word of self-esteem and tend to say, well, is it a question of his esteem at this school?
So he's had a bit of bullying, but he's just finding high school hard, and he didn't do well in some of his exams, and he just doesn't think it's worth it.
I think there is no such thing as a bit of bullying. And until you sort that situation out, you're not going to get anywhere. He's going to stay away from school until the pressure's off him. And then, if you've removed that barrier, you can look at the mood issues that may be still lingering. And some of them, as I say, maybe that self-esteem.
So Brian, we're talking about verbal, physical, cyber?
Cyberbullying, yeah. And I would think that bullying can be a driver around major depression. To kids who are bullied at school, it can be a pretty relentless experience of being a victim, and the sort of feelings of being helpless and hopeless are their real causes of concern around kids' mental health. And certainly he would probably, given his age, because bullying tends to peak late primary, early secondary, that I think they're the issues that I'd want to be exploring with the family. And possibly the school. The schools are invariably seeing this as their number one mental health issue, bullying, and they're clearly, a lot of them are working through policies, but it's also not only at the school level you want to work at, it's also the individual. So I agree with Ross around the idea that you can provide a kid with some tools around how to respond to other kids, and also to how to protect his self-concept, I would say.
So what do you think about this issue of self-esteem?
Well, I think self-esteem it's a concept that people understand and readily use. So I think it's quite useful to talk about it. And I certainly think the things that we talk about in talking therapies or psychological therapies are about providing tools for kids to learn some skills, social emotional skills. So the idea of being able to coping skills, how to be able to negotiate, problem solve some of the relationship issues, there's skills around building self-esteem, but particularly also for adults, you know, that they're able to keep their kids on track around saying, you know, don't always focus on what the things you can't do. Focus on the things actually you are doing pretty well. And the problem with kids who are very depressed, that's the only thing they focus on is what they're doing badly.
So Ross, when you ask the routine questions on depression, really all you get from him is he's just feeling down and low, he's had a bit of bullying, and the question is, do you think he's got depression? Because we've got a question here from Michael, a psychologist in Albury in New South Wales. Albury's New South Wales,
yes,
or rather Wodonga. Yeah, sorry.
Wodonga's the other side.
That's right. Sorry, I had a moment's dementia lapse there. Forgive me, all our viewers in Albury, Wodonga. Asking, are we pathologising normal teenage behaviour? No.
When the behaviour makes the individual unhappy with their environment, then I don't think it's normal. I mean, it's okay to be moody, and it's okay to be a little bit rebellious, but that doesn't make you lose pleasure in life. It doesn't make you lose volition. You still want to go out and do something, but you mightn't feel 1000% about it, but you don't lose the pleasure of being there.
But young James, would you actually interview young James by himself at 14?
No, I'd still keep mum in the room. I sort of draw a line at 14, unfortunately, because that's almost the medical age of consent, if you like. They can do it, but you prefer they didn't.
So what would you do for
16?
What would you do for young James here? It doesn't sound as if he's got major depression.
I mean, in some ways, the distinguishing between a dysthymia and a major depressive disorder is an academic exercise and doesn't necessarily influence treatment. I mean, going back to the question that before about, you know, are we pathologising normal behaviour? And I think one of the problems in psychiatry and a similar problem in other areas of medicine is there's no clear demarcation between normal experiences and mental illness, and we have to draw a line somewhere. And we do draw a line, and we say, you know, particularly if there's a real effect on function together with these depressive symptoms, we'll call it depression.
On the line we've got Eamon Shnuda, who's a general practitioner in Wagga, has been in Australia for the last 16 or 18 years, 9 years in Wagga, graduated in Egypt. And because one of the reasons we've got Eamon on the line is that one of the issues is that many of you watching graduated overseas. English isn't your first language. This is difficult stuff, even if English is your native language and you've grown up in this country. There are nuances and so on. How do you deal with this when Australia wasn't your home country and you are in an alien culture? So, Dr. Shnuda, how did you deal with this right back at the beginning?
I agree. It's a very difficult issue dealing with teenagers in general, and I think it's always a problem to get them to sort of engage them and gain their trust is an issue. Having a different language is always some sort of a problem. But from my point of view, engaging with the community I'm living in did help me a lot, and there was a program about GPs going to schools to talk to teenagers about general practice and about how they can approach general practice and what the opportunities they have in Wagga to be able to access general practice. And this definitely helped me, like being engaged with the community activities. Another thing is knowing the culture you're living in and accepting the culture, and don't be judgmental of the culture, because coming from different cultures with different habits can in depth sort of affect your judgment, and I think the art of general practice is to be not judgmental and to deal with the issues as they are without putting your stamp on them.
Yeah, it must be really easy to say, oh, parents were different where I came from, too tough, you know, too lax here, and you can imagine just all sorts of, you know, even subtle prejudices creeping into your assessment.
That's absolutely right.
What other tips have you got for people who might be at nearer the beginning of their medical career from overseas in Australia, in Australian general practice, particularly rural general practice, where they might be feeling a bit isolated?
Yeah, I think engaging, one of the things is engaging with the community, but also having some peers to talk about your problems and discuss your problems, and trying to have a mentor to discuss the issues, and don't be scared about the issues. I think one of the issues with overseas adulthood is a lot of insecurity that comes with the package of insecure jobs and all of that, and they just have to learn to engage more and to talk about their problems more with their peers, and that would alleviate a lot of fear and a lot of problems.
And how long did it take you to be sort of facile with have an easy relationship in terms of your English skills? Sorry, I'm expressing myself badly, but you know what I mean. How long before you were at ease with your English skills?
5 years until you think in the English language rather than thinking in your own language. And I think one of the issues that I always remind people coming newly or new arrivals from overseas is that they need to slow down a bit with their communication. And the reason for that is that they think in their own language, and that takes some time, and sometimes they miss communication because of that.
Because they're just going through this double translation in and then back out.
Translate things in their own language and then try to translate it in the English language and then deliver it, and all of that takes time in the brain and a lag time that sometimes they miss on the communication in the middle of it, and sometimes writing things and writing notes of what you're doing, it does help it too.
But that skill that we're all taught when we're learning a foreign language is try hard to think in that language and not in your native language.
That's exactly right.
Eamon Shanura, thank you very much for joining us from Wagga. That has been very helpful and very useful.
Thanks a lot.
A question from a practice nurse in Bendigo is, what are the main elements of a good case management plan for an 18-year-old boy with depression? Do the guidelines help us here, Brian?
Not really. I think we probably might need to go to the psychiatry specialist here. Might be a good idea.
A quick flick to the side here, Chris.
Good management plan. So I suppose first and foremost is always having a plan to maintain safety. Doing a good risk assessment and feeling like you've got a good plan to maintain their safety, at least in the shorter term. Then the other elements are, engaging the young person in treatment.
And presumably other things as well, such as exercise, other things that will benefit, perhaps getting out in the light.
Perhaps my own bias, I think exercise and good eating is, not going to be harmful and it's probably going to be beneficial, but the benefits of it for depression are possibly overstated. My own bias would be to think, that probably the most helpful things are to engage people socially, making sure that's sort of socially active, engaging with friends, engaging in meaningful activities.
But it's part of the communication with your colleagues, isn't it, Ross?
I think the essentials are that a plan needs a structure, and the structure needs to be around, safety, but I think it needs to be around the follow-up and the communication between the health professionals involved.
And who's responsible for what?
Yes, and where the communication falls down is when people aren't prepared to talk to their fellow health professionals.
Were you ever handed a written action management plan?
No. I'm familiar with them though, and I did see them in the doctor's office. But
you never got your hands on one?
No.
Do you hand them to your patients?
I hand them the 2710, which is the mental health care referral, and they're quite at liberty. I actually give them their own copy, and I have a copy for the psychologist.
And that has a plan on it?
And that has a plan on it. They're identical. And this is what I feel the problem is, what I expect out of the consultation with the psychologist. As I said, we have corridor consultations on an ongoing basis about the progress. We have also telephone consultations whilst the patient is in there, and we have the facility to call the person across, call me across to the psychologist's room to clarify things, to discuss where things might go if needed. And then at the end of the 6 visits that's allowed on the 2710, we have a review. So I sit down with the patient and find out how they feel the thing is going, get specific feedback from them that they may not give to the psychologist as to what's been good about it, what's been bad about it, what things they think can be improved in it. More or less do a SWOT analysis at that point of time, and then look at the positives that have come out and say, well, let's pursue those harder. Let's see if we can eliminate a few of the less desirable aspects of it and the things that aren't working for you. And let's plug on with the 2712, which is the follow-up 6 consultations. They're allowed.
Chris, how do you know when to stop the medication?
Well, so I guess we're talking here about a depression that's improving, and there's some good literature on this to suggest that stopping at that point is probably not the best idea. That in that period after you're better from depression, for that next 6 to 12 months, you're quite vulnerable to getting depressed again. And I think it's important to
Which goes back to your original thing that you don't want a relapse.
That's right.
Relapse is a bad...
That's right. I mean, there's some suggestion it can trigger even, more likelihood of relapses. But that 12 months after you're better from depression is a particularly vulnerable time. And, the literature perhaps isn't precisely about exactly how long you should continue your antidepressant after your depression is better. I usually say 12 months, thinking that, if they get to 6 months, that'll be good. But it is really important to try to get the young person to keep taking their medication for at least 6 months afterwards. And, it's not an easy thing to do. I think we all know if we've taken medication that it's hard enough to remember to take it if you are unwell, but when you're well, it's even harder.
Have you got comments on how to... Did you stick to it? Were you a good boy?
I did continue with my medication for about 24 months from when I was diagnosed. And that wasn't a matter of me relying on the medication to improve my mood. It was simply a matter of building that resilience so that when I did come off the medication, I knew that I could continue without needing medication. So,
Brian, what resources are available for people watching?
In terms of Beyond Blue has a major focus on awareness raising and particularly information resources, but not only for the general public but also for professionals. So, for example, Beyond Blue has just released a book about what works for youth depression in young people. And clearly the book is for those not only in primary practice but also for the general public. And I think one of the key things...
And that's available online?
And that's available online as well as hard copies, and you can order it from the Beyond Blue website. But I think the key thing is around it's actually the psychoeducation that comes with, explaining what the illness is about, explaining the course and the treatment options is really important. And I think that's one of the main things to stress. The Youth Beyond Blue website that Beyond Blue has is really a website that's really targeting information resources for young people, but particularly around that, which is really useful again for people in general practice to be able to provide young person with information around depression. And it's also for those who basically might have a friend who's experiencing depression, what they can do. It talks about treatment in a language accessible for young people. So, and the third one really is Young Minds, which is really which is an online training program for general practitioners and practice nurses and allied health. And it's really about the detection and treatment of anxiety, depression, particularly around the youth contexts that are around. So. They're the 3 major resources that Beyond Blue currently has in this area.
And Ross, there's the Better Access program.
Yeah, Better Access I think's changed a lot of our ability to treat in particularly rural areas, and GPs have access now to referral to Medicare funded psychologists, clinical psychologists, and there's a list available of psychologists in every area. Contact your division is probably the best way of finding them. And obviously the 2710 mental health referral form is readily available online.
What are your take-home messages for people watching, Ryan?
I think for us it's about saying clearly there's effective treatments out there, and the important thing is for those working with young people that that they're confident they actually have understanding around the illness and they can actually feel confident about starting the process for treating the young person to get better.
Ross?
I think thinking about depression in young people is important. If 1 in 5 are going to have it, then 1 in 5 that walk through your door at least are going to either have it there and then or at least sometime during their contact with you. Always be prepared to explore the situation with them and know where you can refer for assistance and help at all times, and make yourself available.
Chris?
Yeah, similar message really. I mean, depression is common, and despite some confusion in the literature, there are effective treatments.
Jeremy?
Yeah, when you come into contact with a young person who's experiencing probably the lowest point in their life or a crisis, it's important to remember that they're coming to you for a lot of help and to just have the confidence that you can help them in the best way possible.
Thanks, and thanks particularly to you, Jeremy, for coming on and sharing with us. It's not that easy to talk about it. I can see that even now, so thank you, and thank you to you all. And I hope you've got a lot from tonight's programme on depression in young people. Our thanks to Beyond Blue, the National Depression Initiative, for making the programme possible, but thanks also to you for taking the time to attend. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available, both on the Rural Health Education Foundation website, that's rhef.com.au, and the Beyond Blue website, that's at beyondblue.org.au. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Norman Swan, and I'll see you next time.